Our first speaker is Ray Bennett, who I recently have had the privilege of meeting and working with. He's a flight nurse with Cooper Air Medical Service, 40 years as a pre-hospital provider, 34 years as an emergency critical care transport nurse, and has 3 years as a coordinator of a local New Jersey stroke program. So welcome, Ray, and we look forward.
Thank you. As you said, a lot of my stroke experience comes from being in her position at another stroke center in New Jersey. But since I don't work for them anymore, I won't say who that was. But when I was asked to do this presentation and given the topic, they said, we need you to explain what EMS does. And I'm like, okay, well, I like to have a catchy title. So I was talking with my wife, who's a teacher, and we're like, I need to try to explain to this group, how EMS decides where they're going to go with the patient. So we're trying to think of a title. I said, well, Dr. Seuss, because Dr. Seuss's birthday was a couple days ago. It was March 2nd. So we figured, what a good title. So it kind of fits. I don't have any disclosures. I'm not going to talk about any products. I don't buy any. I haven't bought stock in anything. I was a speaker for Genentech when TPA was an MI drug, but that's like ages ago, 15, 20 years ago. It was a long time ago when it was just becoming a stroke drug. But I used to speak for it as an MI drug. This quote from Dr. Seuss kind of puts out what I want to say, is that the more you know, the more you read, the more you know, the better decisions you make. And this quote kind of says that. Obviously, we have objectives. These are what I'm going to achieve. But more importantly, these are the questions I was asked to talk about. Okay, when Terry contacted me and Chris contacted me and said, we want you to talk about what EMS does and explain to emergency nurses and hospital nurses about how to decide which hospital they get to. That's kind of what. So the question was, how do they determine they're having a stroke? How does EMS decide they're having a stroke? What treatment do they provide? What little treatment? And most of it's transport. How to decide which hospital they're going to transport to. And, what education does EMS ultimately have? I mean, what their perspective? But you need to think about it. In this world of stroke, everything we've been talking, stuff that the physicians talked about this morning, is new. January of 2015, the world of stroke drastically changed. The whole concept of endovascular therapy in the last 4 years has taken a complete turn and gone a new direction. And most of us providers who've been doing it for many, many years, unless you come to conferences like this, you don't understand what we're doing or where we're at. And a lot of stuff you learned in school doesn't pertain anymore because everything has changed so rapidly. So a little bit of scope of where we're at with EMS in New Jersey. There's 26,000 EMTs. There's a lot of people to educate, since they probably didn't get this education in their primary education because it's all 4 years old. Unless they come to conferences and do continuing education, they're probably not that knowledgeable. So that's something to think about. Of that, we have 1,700 active paramedics that are actually doing it. There's 800 plus BLS agencies. There's 29 ALS agencies, and a ton of vehicles and ambulances, and these are statistics right off the Department of Health website. There is a stroke advisory panel. They kind of decide where stroke should be going and kind of set the direction. If you go back to 2004, what they decided is that they went out and said, who wants to be a stroke center? They were talking to hospitals. And like 65 hospitals in the state all said they wanted to be a stroke center. So they designated everybody a stroke center. And that was the only designation, that's the only inspection they ever did. There was no real site survey. Of those 65 hospitals, 29 have actually gone through Joint Commission accreditation and actually have been inspected by the Joint Commission and actually are true, at least a primary stroke center. I think we're up to 7 comprehensive stroke centers now, or is there 8? I've lost count. But there was 13 that said we want to be comprehensive stroke center when the state asked, back in 2004, but only 7 or 8 have actually gone through the 2-day formal Joint Commission accreditation inspection, which Cooper's going to go through theirs for the 3rd time next week. So they're, building up for that. There was a EMS field guide that was put out to help guide our EMS providers. And a lot of what that information is they need to go to the most appropriate facility. Okay, and that's actually the current language. There is no official designation from our Department of Health, from the Office of Emergency Medical Services, of where EMS should take stroke patients. The only real guidance they have is that they should go to the most appropriate facility. The state right now doesn't officially tell EMS, go to a comprehensive, go to a primary. They met in 2017. I have a physician friend who's on that panel, and they were real hesitant about making that decision as far as telling EMS that if you have a person with these symptoms, large vessel, stuff that I'm going to talk about, go here, go there. It's the most appropriate decision based on their medical command, medical direction. You know, the paramedics talking to their base command, and we'll get into that. There is legislation pending, and the last I looked, still hasn't made it through all the committees in the House and the Assembly in New Jersey, so it hasn't really gone anywhere. But there is Joseph Vitale, who's real active in healthcare issues as far as New Jersey Assemblyman. They're trying to push to make more designation and more direction, but it's not there yet, unfortunately. Okay, so when you call 911, you're saying you're having a stroke, what happens? Now, to give you a little background on me, when I was a manager of an EMS system for 14 years, I was responsible for critical care transport, but at 3 o'clock in the morning when I was on call, as the manager on call for the system, I'd get calls from our dispatch center, and they'd have a question. I'm like, I don't have enough experience. So I actually went to my director and said, I need experience. So actually, I became a 911 dispatcher. I went through all the training, and I have many hours and many years as being a manager, but filling on-call shifts, call-outs, and I've sat in this chair, and I know exactly what these dispatchers go through. But when that call comes in, they have to make a decision as far as what's happening, which resources to send. Do I send a regular BLS ambulance? Do I send ambulance and medics? Do I send a fire truck, first responder? Do I send police? A lot of decisions that these dispatchers have to make. A lot of it is kind of set in guide cards. These dispatchers have resources, some of them that's computer automated, some of them are flip cards depending on where their dispatch center is, but this guide card says when you come in and you call 911 and they say, you know, what's happening, and you say, I think I'm having a stroke, they start asking questions to clarify whether you're having a stroke or not. And then down the bottom it says, you know, who should they send? And on the next card, it tells that dispatcher, send this particular level of care. And it also gives the dispatcher instructions to give that person who's calling what they should be doing until the ambulance actually arrives. So that's what happens on the 911. Now, everybody watches the police shows, NCIS and all those shows, you know, where someone calls on a cell phone and they know exactly where you are because it comes up on a map and that blinking thing. Yeah, that's not there. That's TV world, okay? If I was standing in this building and I picked up a building phone and I called 911, on that computer screen in front of that dispatcher, my number would show up with the address because I'm at a building. They may not know where I'm at in the building, but they know what building I'm at, they know what street I'm on if you're calling from a building phone. How many people have gotten rid of their house phone and you just have a cell phone? What happens when you call 911 from a cell phone? In New Jersey, your number goes to the State Police Dispatch Center it's in Hamilton, actually. It's in the Rock, it's in Hamilton. And that dispatcher takes all cell phone calls, and the first question they ask you is, where are you? And if you don't know where you're at, that's a big problem because they can't geo-track you. You know, that CIS ping, they don't really know exactly. They probably know within reason where the call is coming from after a while, but they ask you where you're at. As soon as they identify what local town you're at, then they'll transfer you to the dispatch center like this in that local town, and then the process will start. Now, what's that process like? They're going to try to, actually how accurate, my next slide is how accurate that slide. It's amazing when you look at these statistics. There's a lot of studies done on stroke and whether these dispatchers over a phone call could identify whether you're having a stroke. And it's about 50% accurate. And I did this presentation back in 2013 and I updated it and I found this last one, which is actually Philadelphia Fire from 2017. And they actually, what was interesting is that the dispatchers identified some patients who were stroke, that when EMS got there, said, oh, you're not having a stroke. Person got to the hospital, and they were having a stroke. So the dispatcher was right, which is I find very interesting when some of the data from that Philadelphia study. But 50% of the time, for the most part, that dispatcher taking information over the phone can be pretty certain that you're having a stroke. So when they dispatch the local EMS, they're actually telling telling the EMS you're going to a stroke call. So call comes in, and hopefully I won't blast you out. I got two audio sounds.
Emergency Medical Services, where do you need the ambulance?
Hello, I live at 28 Cosman Street.
And that's in East Brunswick?
Brunswick.
Okay, what's your phone number you're calling from, just in case I need to call you back?
732-257-8825.
Okay, what's wrong today?
I'm experiencing extreme dizziness, and I'm here alone. I've never had this like this before.
Okay, how old are you, hon?
71.
71. Any medical problems?
Yeah, I've got this thing. I went to the doctor.
Emergency Medical Services, where do you need the ambulance? Emergency Medical Services, where do you need the ambulance?
Trying to get to the
Hello,
other one.
I live 28 Cosman Street.
And that's in East Brunswick?
Like,
Okay, what's your phone number you're calling from, just in case I need to call you back?
732
Uh-huh.
257.
Let me go back. Let me get the other one. This other one's actually interesting. The other one I'm going to play for you, it's actually going to be a little softer, so you may have to bump the volume up a little bit. It's actually a person who's in his car on a street somewhere, realized he was having a stroke. Oh, come on, play.
Hello, where's your emergency?
Stroke.
Person who's aphasic.
You're alone? What makes you think you're having a stroke? Okay. What's your address, sir?
Failure Street.
You're outside?
I'm in my
Your car? What kind of car do you have?
the white Chevy.
Pulled over.
See you, I'll play it like,
Okay, but you're pulled over, right?
yes.
What's your phone number?
So,
I put those videos, those audio files in because I want you to, it's a difficult job being a 911 dispatcher trying to figure out what's going on. They need to ask the right questions and they don't have a lot of medical information. The medical expertise of the DMS dispatchers is really what an EMT is. It's 120, 140 hours worth of training. And they need to pull out, ask the right questions to try to identify, and as I showed with the studies, about 50% of the time they're right with getting that information out there. Now what's going to happen is that once they identify where you're at and who to send, they're going to dispatch a tone, activate the crew that's there. They're going to give them information like squad 169 and the medics. You're being dispatched to this address for a stroke. And then once that ambulance crew and medics get in their ambulance and going, they usually give them what's called a short report. They give them more information of what they obtained off that phone call. So you go into this address for an 82-year-old female with difficulty speaking, right arm weakness. So as a pre-hospital provider, that's all I know. Now I spend 4 minutes, 5 minutes, 10 minutes, whatever my drive time to get there, and that's the only information I know until I walk in. So as an EMS provider trying to figure out what I need to do, where am I going to go, that's all I know going into the house. I don't get much more information than that. When they get there, obviously they need to do a stroke assessment. But what do we expect from EMS providers? There's two different levels. There's basic EMTs and there's paramedics, and they each have a different perspective. And again, what we're talking about at this conference is less than 4 years old. Any paramedic and EMT who's been in the field for more than 4 years has not gotten this into training unless they've gone through continuing education like we are, like what we're doing right now. So my job for the last several years has been trying to get that education out to them, but there's 30,000 EMS providers in the state of New Jersey. I know I've not gotten to all of them. So some of them have good experience, some of them don't. So it's a little bit of a mixed bag out there. Okay, when they're in the house, obviously what they need to find out is what the chief complaint is and does it match the information I got on my dispatch report. Is a patient a good historian? In the situation like right here, sometimes the patient knows their history, knows what medications they're on, knows what medical problems they have, and they provide good information. They do a blood sugar because that's part of ALS. Is a person a diabetic and have a low blood sugar, or is it normal? They get a set of vital signs. They do stroke assessment tools, and we talk about two levels. Ones that they do right there in the living room, in the bedroom, in the house. I think you're having a stroke. We'll talk about that in a minute. And then they do a more detailed one, probably on the way to the hospital, so when they walk in, they can say, listen, these are all the deficits I found, okay? One of the most important things we ask of our pre-hospital providers is to find out what time the symptoms started. And then, obviously they need to have a clinical impression, and the biggest thing that EMS can do is rapid transport, because there's not a lot of drugs, not a lot of therapy that EMS does pre-hospitally for stroke patients other than rapid transport. Now, ideally, this is the best situation. The person knows their history, they know their medication, but you know what? I've been an EMT since 1979, so 40 years. I've gone into a lot of homes. I walk into this, and I start asking questions, and the person I'm talking to doesn't know much. The person with them doesn't know much. And, emergency nurses here, and you walk in and you complain that the EMS doesn't give you good information. We try. We try to get the best information, but sometimes the best information isn't there. Because I say, sir, where's your wife's medications? And they go, oh, it's on the counter in the kitchen. And I see this on a daily basis. Yeah, I can't find a medication. I have no clue what medications you're on. So it happens. Now, in the EMS world, their basic training, we do teach them some things. When you get a person with an altered neurostatus, an altered mental status, these are the things that you need to go through, and this is a basic, algorithm we sort of teach them to go through. And in their history, we teach them things to assess for, look for, and it may be a stroke, it may not be a stroke. This is part of that diagnostic impression that we all have and we have to sort of work through. We teach them basic mental exam, mental status. AVPU is our basic thing, followed by a GCS score. This is part of our basic neurostatus. And actually, if the one thing EMTs are good at and medics are good at is the Glasgow Coma Scale, right? Stroke patients don't play nice with the Glasgow Coma Scale. They may be alert, eyes open. They may be cognitive what's going on, but because they're aphasic, they're nonverbal, they have garbled speech, so they get a low score. And then they move one side of the body but not the other. And which side of the body does the EMS score? The side that's not moving. So they come up with a Glasgow Coma Scale of 6. What do we know about anything less than 8? How many stroke patients do we actually intubate? Very few. So this stroke scale doesn't work. This coma scale doesn't work for stroke patients, but a lot of people try to apply it, especially EMS, because they don't have a lot of experience, so they try to apply it. So it's kind of interesting. What they do have is our basic stroke scales. And I'm going to go through 3. There's actually more out there, but we'll go through 3. The most common, if you've taken a CPR course, anybody who's taken a CPR course, the Cincinnati or the FAST exam is part of your basic stroke score. So all of our EMS providers know the Cincinnati or the FAST exam. How accurate is it, if your one part of it is positive, what's the likelihood of a stroke? 72%. If all 3 are positive, what's my likelihood of a stroke? It's only 89%. It misses 11% of strokes. Which strokes does it miss? It misses all posterior circulation strokes. So there's been a big push in my world as an educator trying to get out the EMS is to teach them something that's going to give them more. So BFAST is one of our big things because the B and E look at posterior circulation issues. So we're trying to teach BFAST. State of Connecticut actually came out with SAVE and sudden, which I think is much better. But the SAVE and sudden looks at sudden onset of symptoms, which whole drops down to that lower thing because if you've been having gradual onset of neurologic symptoms for 2 or 3 days, you're probably not a stroke. If you're sitting there having coffee and I spill, and I'm probably a stroke. So sudden onset is a big issue. But it could be cognitive. It could be, a lot of different things, trouble speaking, dizziness. So SAVE really works. And SAVE is very similar to BFAST, but it's a good way of thinking about it. So a lot of the education we're trying to get out to our EMS providers is this because it's more conclusive than just doing the FAST exam. Now, anybody from the left coast, from California, the LA pre-hospital scale was the other big one that was real big for a while. It's kind of died out because I think FAST and Cincinnati have really overtaken it. But this one's nice because it asks 5 questions. What age you are, I'm not quite sure why that's important in California because we talked about this one, you can be younger than 45 and have strokes. It talks about blood sugar. It talks about a seizure disorder, which could be Todd's paralysis, which is a whole another lecture in itself. So it tries to identify other things. It looks at hyper and hypoglycemia. What I find interesting about this scale is that there's no verbal. All these tests are motor. Big smile, arm strength, and grip strength. And I think if I'm flaccid in one arm, I probably don't have grip strength in that arm. So I think it actually tests the same thing twice. And so I don't think it's as accurate. And actually, how many of you held a newborn in your hand and gave him a finger? Reflex action to grab, right? I've had intubated head trauma patients in an ICU and families grab their hand and they get this reflex action. And they go, they squeeze my hand. Well, is it because they're reflex action or is it because they actually have the knowledge? What I like better is to show me 2 fingers because it's opposite of that reflex action, okay, which I think defeats this grip strength on this exam. Another exam that's out there that we teach EMS, and this is actually a full 8-hour course. I don't know if anybody's taken the full Advanced Stroke Life Support course. Great course. It teaches an exam called the MEND exam. But this was great up until about 2015, and then there was no data supporting stroke severity and large vessel, which they went back and did. They actually added that a year or 2 ago to try to compete with all the stroke scales. And if you got a certain score, what's the validity of the score? But it's kind of died off a little bit because there's other things that's more important. This is really where all the focus of EMS education to our EMS providers is at right now, and that is stroke severity scales. Anybody have ever heard of stroke severity scales? There's like 12 of them because everybody at the same time, all across the country, across the world was trying to develop stroke severity scales, so there's plenty of them out there. I picked 3. I have another talk that I do that I have all 12. They're all very similar, but the one thing that they lack is they don't do a lot of posterior circulation as part of the exam of these stroke scales. Okay, but the FAST-ED is one of the more popular ones. Okay, RACE I know is big with our Cooper team. Our Cooper EMS is doing RACE exam. It's a little confusing in one point is that there's 6 categories. You go down 5, and then if the deficits are on the right, you do the 6 this one, or if they're on the left, you do the 6 that one. So it's a little bit of confusing in that respect. If you're right-sided deficit or left-sided deficit, those last two boxes. But the whole point of this scale, or these scales, I'll go back a little bit, is if the score is high enough, we think they may be large vessel. And what we're trying to get into our pre-hospital providers is that if you identify large vessel in the field, it might change your destination. And of course, I said the state of New Jersey leaves it up to their medical direction to decide. Other states have given it more, let's go in this direction with it. Now with these scales, and this is the Van scale, and I like this, I found this, if you're looking at one of these scales, and what do we know about large vessel disease? When I have a large vessel proximal occlusion stroke, how much brain is it taken out? A whole lot. So when you're thinking about that, if you look at this diagram, and I'll just point out the RACE scale there, it identifies a lot of areas of the brain on that one scale. Where if you look at the center one, actually the far right one, which is the LA pre-hospital scale, it really only tests one part of the brain. So the LAMS, which is the stroke severity scale of the LA pre-hospital scale, they add scoring to it. It only really tests one part of the brain. So if you're looking at a scale to use, and again, there's 12 of them out there, you want one to test different parts of the brain all at the same time in your exam. And I think the RACE, the VAN, and the ED are the 3 most popular. And actually, I've been advocating, and I do it in one of my other talks, about ED triage nurses doing the stroke severity score at triage. So on the way to CAT scan, you already have an idea that it's probably large vessel. So you're actually doing that stroke severity score in the ED, sending the person to CAT scan, and you have an idea that they're probably large vessel, and you're actually starting your algorithm going towards the angio lab to get large vessel, and you're starting that process much sooner. That's one of my things that I sort of like, my soapbox I like to stand on. Now, in 2017, the American Stroke Association came out with this nice diagram in February 2017, and I'll blow it up a little bit. In the center, this circle right here, it says that if the stroke severity score is high enough, if your transport time from your scene to a comprehensive stroke center only adds an additional 15 minutes, consider going directly to the comprehensive stroke center. Okay, and the thing with that is there's no scientific evidence to support that. That was a consensus opinion. That was looking at all the data, all the things we've done, all we know about good outcomes with endovascular care, but there's no research study to support it. We haven't been able to do a double-blind controlled study with 400 people in one group and 400 people in the other group, and we don't really know if it's truly scientifically valid. But we have enough data from doing endovascular care that says it's probably better off. But in March of 17, this was what the position statement was. These posters got put everywhere. The place where I work as a medic, we have them all over our station. In March of 18, this number 4, they put out their scientific evidence. They listed that concept of bypassing going as a 2B consideration, like, ACL, SCR 1 and 2, 2A, 2B. And then a month later, they said, no. They pulled that. And now we're a year later, and they still haven't come out with a scientific stance. So a year ago, for the last 2 years, it was up until March of last year, or April of last year, consider bypassing. And then when they pulled that statement and said, we don't have data to support it, we can't say that. So there is no official stance from any major organization of bypassing a primary stroke center to go straight to a comprehensive. Only because we can't study it. Not that we don't believe it, consensus opinion probably says, but we don't have data to support it. So if you're wondering why EMS bypasses you or not bypassing you, what it comes down to is the medics, after assessing the patient, taking all the information appropriate, have talked to their medical command and that physician on the end of the medical command has made the decision, yes, bypass and go direct. One of the other things that we're asking our pre-hospital providers to do is do a modified Rankin scale. Now, the modified Rankin scale is actually for physical therapy 90 days post-op to determine what type of deficits the person had after the stroke happened and 90 days afterwards. We're asking our pre-hospital providers, because the criteria for going to endovascular, the patients who do better prior to the stroke, prior to the deficits they have right now, were a 0 or a 1 previously. Okay? So we want our medics to say, what was their lifestyle before they had this current set of stroke symptoms? So we know, because if they were already a 4 before this stroke, they're probably not going to have a good outcome. So we are asking our pre-hospital providers in some areas, and I know in Trenton area, we're obligated to document and chart this, but it's just to try to identify what the person was like before the current stroke. Were they a person that was normally active and healthy, and they went by their normal ways, and they drove, and they had a normal lifestyle? Okay. One of the biggest things we try to get out of our EMS providers is last known normal. When was the last time the person was seen without symptoms? Now, if I'm a person that hates the evening news because it's too much political and I don't really care, and I go to bed at 11 o'clock and I turn it off, and at 3 o'clock in the morning I wake up with symptoms, when's my last known normal? 11 o'clock, okay? But I've learned that you got to ask more questions. You know, I've had patients at 7 o'clock in the morning that were fully dressed, but they lived by themselves. They had their makeup on, and the receiving hospital got them and said, well, you went to bed at 11 o'clock last night, you're a wake-up stroke. You're now 8 hours into it. And it's like, wait a minute, but they're fully dressed, makeup's perfect. If I was flaccid on one side, I probably couldn't have shaved. I would have nicked myself, and I probably couldn't have put my makeup on. The other question I like to ask is, are you a person, because a lot of old people get up in the middle of the night to go to the bathroom. Did you get up to go to the bathroom? Yeah, I went up at 3 o'clock, I went up and peed. And you went to the bathroom and made it out fine? Sure. So my last known normal is not 11, it was 3. So it's really a matter of figuring out when the last known normal is and what's the normal routine, okay? So it's a lot of stuff we really push on the EMS. Now with history, this stuff that's up there, I don't really care about. The only thing I really care about is what medications are they on. Are they on any novel anticoagulants? Are they on Coumadin or anything that would affect me giving TPA? That's the most important information of the history that I need. You know, whether they have hypertension or not, if they're hypertensive now, I may treat it. You know, if they're AFib, I may treat it post-stroke, and we're going to try to get them rate controlled. And, you know, if they've had recent surgery, that's important, but it all depends really what that surgery was and how long ago it was. I mean, as a stroke coordinator, I've given TPA to patients who had cardiac cath that morning. Now, is that a surgery or not a surgery? You know, so it really defines, you know, what it was and how long ago it was. Okay, pre-notification. That's probably the biggest thing EMS can do to change outcomes. It's as simple as this.
780 Med Central, call a brain attack. We're en route Robert Wood right now.
That's the most important thing the EMS can do that changes outcomes. If they don't do anything else, if they call and notify, because when we know they're coming, we're ready. Our door to needle time, our door to CAT scan time, our door to puncture time is much quicker when we know they're coming. If you can get any message out to the pre-hospital providers that come into you on a daily basis, is call. Even if you're wrong 25% of the time and it's not a stroke, activate us. You know, that's probably the biggest thing you can do to improve your door to needle time. Wake-up strokes, you know, a lot of hospitals, you know, used to have only called a code stroke or brain attack within a 12-hour window. Now it's up to 24 hours because with the Dawn and Diffuse trial that we talked about this morning, these patients are now probably eligible for treatment. Yes, they're probably not eligible for TPA because they're outside that 4.5-hour window, but they may be eligible for other treatment. So we need to get the message out to our pre-hospital providers that call that brain attack, that code stroke, whatever terminology you use, up to 24 hours because they may be within the window of that treatment. Okay, EMS treatment, what do they have to do? Do no harm. Check blood sugar to make sure it's not a diabetic. You know, if they're hypertensive, don't treat it. That's one of the messages we're getting out to them. Leave them high because that's the only way that we're perfusing the brain. Let the blood pressure stay high. Obviously, don't let them aspirate, nothing to eat, NPO. Get good transfer care. Some areas in New Jersey, up north, are actually doing FaceTime or video, so the doc at the receiving end can actually see the patient, and do the neuro exam, the deficit exam pre-hospitally. Atlantic, up in North Jersey, Morristown, that area, their medics have had video transmission for a while. It's a little cumbersome, the units they're using. FaceTime would be even better. And there are some FaceTime type softwares that are HIPAA compliant. So if we can get EMS to do this so our base physicians can actually see the patient, that would be phenomenal. It is tried some places, but it's not overwhelming yet. But if we did our exam before they got to the hospital, we'd get to the CAT scanner that much quicker. They talked about this morning about neuroprotective agents. There was a study down in California a couple years ago called FastMag, looking at magnesium, giving IV magnesium as a neuroprotective agent. And the unfortunate thing is magnesium is not that drug. The good thing is this study, which was a large multi-agency, multi-hospital study, proved that operationally, if we find a drug that's a neuroprotective agent, the system will allow it to happen and get given before they get to the hospital. You know, getting a good stroke exam, good clinical exam, calling the medical command, getting the orders, and actually doing it. The system itself works. Unfortunately, that drug, the magnesium, that's why it's called FastMag, didn't work. But, you know, it was nice that the speaker this morning talked about, Dr. Joven, in neuroprotective agents, because that is where I think the future is for a pre-hospital environment. Giving a drug that will help protect the brain so the penumbra doesn't get any worse on the way to the hospital. Now in New Jersey, these are all the stroke centers. Again, we don't have, nationally they recognize stroke-ready facilities. We don't recognize in New Jersey, we recognize primary and comprehensive. The biggest thing is that we recognize state designation and actual Joint Commission accreditation. There's a big difference in that. But I spoke at a national conference and I spoke to some people from, I believe, Wyoming. There is no comprehensive stroke center in Wyoming at all, none at all. Okay, if you had a stroke in Wyoming today, they have to fly you to like Utah or somewhere else to get a comprehensive care. But in New Jersey, we have 8 comprehensive stroke centers that are Joint Commission, or 7, whatever the number may be. But we have, so if you have a stroke in New Jersey, you're pretty lucky, as opposed to some other states. Iowa, I think, has 2 comprehensive stroke centers. So, you know, we are pretty lucky. Now, we are trying to get out to our medics that, you know, the comprehensive stroke centers do have 24 hours capability, and it is significant. Now, one of the biggest questions right now is, should they go there direct? And I sort of started talking about that with the American Stroke Center approval, you know, of their diagram that said 15 minutes. But there's some places in New Jersey where I fly with Cooper's helicopter. We cover Vineland and Millville and Salem, and, you know, to get to a comprehensive stroke center, the fastest way would be to fly. Now, I'm with Cooper 8 years. We haven't flown any strokes from a scene that I know of, but when I was a stroke center coordinator up at the other hospital in North Jersey, we had 2 flown in to us. They did very well because we were daytime, everybody was there, and we actually had them on the table getting their groin punctured from 25 minutes from landing on the helipad with TPA given, CAT scan, and right to the you know, to the angio table. Is it something we need to think about it? I tell you, 4 years ago, when I first started doing these type of presentations, and there was people from the Department of Health in the room, they were like, we can't use a helicopter to fly strokes. Why not? Why shouldn't we? Why shouldn't we look at our protocol? I mean, right now we know that the better care is endovascular care. It's only available in certain places. Why aren't we? We're still having that discussion. It's not there yet, but it's moving towards it. But what do you have to consider if you're going to make that discussion? Obviously, last known well time plays into that. Stroke severity score plays into that. The treatment window, if I'm 6 hours into my stroke, why are you taking me to a primary stroke center? They can't give me TPA, they can't do anything for me. Why don't they go to direct? So, I mean, where are they at with that door to needle time? Are they already beyond that? The distance and transport time. And that's, again, I can say this stuff, but there's no evidence to support, and I'll put it right out there, that we have an evidence-based double-blind study control group, but we probably can't because there's too many variables to try to control it down to actually do a formal study. What it comes down to is a medical command decision, okay? And right now in New Jersey, you know, the decision to go to bypass, so how many work at a primary stroke center that you think your volumes drop because medics are going direct? If that's happened to you, it's probably because this conversation has happened. Yeah, when I started as a medic, we used to use that box, so. This show came out in '75, I started in '83, and we're still using equipment like that, so. Yeah, so it's a medical command decision, sort of making that decision. So let me show you a couple cases to give you an idea of where, things are. Remember the very first call, my friend Rhoda, who was a dispatcher, was talking to the nice little lady. This is the paramedics got to her house, and actually, this is the medic calling the doc for that medical command call.
Go on, Patch.
Okay, stand by for doctor.
They call in the dispatch, and dispatch has to kick them over to that phone and the ED to the doc. You hear the siren in the background, rapid transport.
Dr. Gale, go ahead.
Good morning, Dr. Gale, Medrescue 2, paramedics, both paramedics. They're coming to you with a brain attack. So many DTAs. A 7-year-old female was complaining of some lightheadedness and weakness starting today. We did find her in a new onset AFib, rate variable between 100 and 180. And she also found some left arm weakness and left facial droop and slurred speech, which is noticeable to her. Vital signs as follows: heart rate is 130, the nature of this. That's 98% of room air. Black blood pressure 170 over 100. Blood glucose 158. It's probably unremarkable. As far as this person is pleased, we want to do anything for rate control. Like I said, it's a new onset AFib. Rates has been about 120 most of the time. And actually, we are finding her. She's pretty hypertensive at this point. If you want to do anything to blood pressure control, or anything the beta concentrated.
Yeah, this is from a few years ago, so the blood pressure control was an issue. But this is basically, it's the 71-year-old female. She called 911 complaining of new onset dizziness. They found her alert and oriented. She's got a left arm and leg weakness, and she has that dizziness from slurred speech. Okay, she's Cincinnati positive, and she had there's her assessment. Okay. She did receive TPA. Okay. She actually underwent an endovascular therapy with angioplasty and did very well. But sort of planned just to give you an idea of what the paramedics were trying to get out there. Now, not all the calls are that straightforward. This one I like, and this may be.
Go on, Patch.
Phone patch, Med Central, this is Med Rescue 1. Inbound to Robert Wood Johnson with the adult patient. Brain, please.
Brain attack. Okay, very good. Stand by.
Rhoda, thank you.
Uh-huh. Here, Patch, stand by.
Hi, it's Dr. Barr.
Dr. Barr, this is Ed, Med Rescue 1. Hang on. Turn out that siren! Thank you, Dr. Barr. I have a brain attack patient
It's
for
a
you.
life
I
we
have a
live.
66-year-old male. The BLS crew found the patient in the parking lot trying to drive his car. He had the wheels spinning on his car. They secured the car, put him in the ambulance. The patient is conscious. He is not alert. He is confused. He's answering simple questions. The patient cannot smile. He's got a right side facial droop. The patient speaks clearly when he answers, but he's confused. He cannot give simple answers. He has right side weakness in his arm, in his right arm. His left arm is okay. He is able to move his right leg. It's a little bit more diminished than on the right-hand side. Patient has history of CVA, history of MI, history of hypertension.
Just trying to give you a picture of what we kind of get into. He did get TPA, he had an M2 clot. He went home functional after 4 days. Okay. The other thing, we live in a world, and there's a couple transport nurses that fly and do stuff that in the room. Critical transfers. When we get called to do a critical hospital transfer, these are truly time-critical transfers, so they're drip and ship. So if we go out to a primary center, there's two things we look at. door in, door out. And that's not only from the time the patient arrives at that hospital to the time they're leaving, but from the time I arrive to package them and get out. These are times that we measure. And if you're trying to set benchmarks, one of the benchmarks you might want to set is from the time that person arrives to the time they're actually leaving, how quickly can you get them identified, CAT scan, teleneurology, medication started, and out the door. And from my role as a flight nurse, from time we do skid to skid time. From time I'm landing, packaged, on my stretcher, and out and back in the helicopter and lifting, how quickly can that be? Because what we learned this morning is time critical transfers. Okay? And I want to just briefly touch about this because I know Dr. Joven talked about this morning. Stroke trucks. The very first stroke truck was the one on the far left, which was in Houston, Texas. Dr. Grad, I got to meet him a few years ago, phenomenally brilliant man, one of the godfathers of stroke across the country. Right now, what they're doing is they're doing a week on, week off study. This week that truck's in service, next week it's out of service. That's the controlled, not controlled group. What he's trying to prove is how effectiveness it is. And his early numbers, and he's not there with his total patients. He's looking at like 2,000 patients before he stops the study. But what he's looking at is to buy the truck is $1.2 million. To operate that truck is about $700,000 to $800,000 a year, depending on salaries and engine oil changes and the maintenance of the truck. If I have a patient who gets TPA within 9 minutes because I'm in their driveway and they have phenomenal outcomes and they don't go to physical therapy, they don't need physical therapy, and I save them, they go home from the hospital in 4 days and they don't spend 3 months in a rehab center, what's my cost saving to society? Probably about $100,000 per patient. If I have 7 patients, maybe 8 patients over the course of the year that I stop from going to rehab, stop having a 4-week hospital stay, and I save that $800,000, I've paid to operate that truck from a societal standpoint. From a business marketing perspective, I can't bill that much to cover it. I don't do enough strokes, I don't cover enough to actually cover the cost of the truck. But from a society, we probably save the money as a society. That's the argument. Now, the lower one is Cleveland Clinic. That was number 2 in the country. The upper one is the one we have in Mercer County in Trenton. It went up about 3 or 4 years ago, and it's still, it runs 16 hours a day, 7 days a week. Very few strokes after midnight, so they don't staff it. It's not cost effective to run after midnight. Inside the truck looks like that. That CAT scanner is only a 16-slide CAT scanner, so it only looks for like big blood, and that's it. But it's enough to make the decision to do TPA or not TPA. There is video teleneurology in there, so the physician beams in and can look and see it and do a clinical exam. Now, these are nice, but this is the monster. This is in Tennessee. This one actually has a full CAT scanner inside. There's a full CT angiogram. It's a 63-foot truck. I got to see it at a stroke conference many years ago before we actually went into service, but it's in Tennessee. I forget actually which city. Okay. Did I confuse anybody, lose anybody? Did I provide you with good information? Got to end with a little bit of a fun note. Any questions? Then I thank you for your time.